Hi, I'm Steve Wexner, Chairman of the Department of Colorectal Surgery and Director of the Digestive Disease Center at Cleveland Clinic, Florida. I'd like to speak to you about the very exciting, innovative, and important new National Accreditation Program for Rectal Cancer sponsored by the Commission on Cancer of the American College of Surgeons. To give a little background, ever since Bill Heald described total mesorectal excision in the early 1980s and Phil Quirk looked into the issues related to circumferential resection margins and total mesorectal excision, there has been a tremendous change in the paradigm in the way rectal cancers are treated. The pioneers of these efforts were not only Heald and Quirk and subsequently Gina Brown, showing us how appropriate preoperative MR imaging could help best select who should receive neoadjuvant therapy and in whom neoadjuvant therapy could be safely omitted with the same expectations for curative surgery. Europe has taken a lead in this regard, first in the United Kingdom, as one might guess, given that the champions were all in the UK, but very rapidly spreading out through Scandinavia and Western Europe and then into Central and Eastern Europe and elsewhere. Basically, this paradigm shift was multifold but all interrelated. Multifold because the realization was not just that the performance of an appropriate oncologically sound total mesorectal excision with obtaining tumor-free circumferential resection margins and an intact mesorectal specimen was important for outcomes, but also that working together with the specialists in colorectal pathology and in rectal cancer imaging was also critically important. So the team evolved. It became known that it wasn't just the surgeon who was fundamental to the outcome, but instead it was the team, and the team would make the decisions as to what is best in terms of neoadjuvant therapy, adjuvant therapy, surgical approach, as well as timing of surgery relative to any neoadjuvant therapy. So these multidisciplinary teams that evolved in Europe were noted as time went on to be associated with many salutary effects for the patients, including in the immediate postoperative period, better outcomes in terms of a higher percentage of good quality TMEs with tumor-free circumferential resection margins. And then in the longer term, not surprisingly, lower rates of local recurrence and better survival. Along with these oncological parameters were also statistics on decreased rates of permanent stoma creation, as well as other benefits such as decreased morbidity, and very importantly, more appropriate use of neoadjuvant and adjuvant therapy and better adherence to guidelines. In 2011, Feza Remzi, then chairman of the Department of Colorectal Surgery at Cleveland Clinic, approached me in my role as the president-elect of the American Society of Colorectal Surgeons and said, we really should try and do something like this in the United States. Now, I knew, because I'd been privileged and honored to be part of the prior effort, that about 10 years earlier, David Rothenberger from the University of Minnesota tried a similar effort, but the timing may not have been right, and David's ideas were superb. We decided to build upon that framework. And in building, we said, let's make this interdisciplinary, but let's focus on the perioperative period so we can really engage the people who have made the most impact in Europe, the imager, the pathologist, and the surgeon. And of course we involve radiation and medical oncology, but not to the degree of looking at the nuances of the timings of therapy in the exact agents administered and the methods of radiation oncology. So under, again, Feza's guidance with the assistance of David Dietz and John Monson, Mariana Barrow, Jim Fleshman, Rick Green from the Commission on Cancer, and others, we assembled a group called the Ostrich. The Ostrich had the mission of proving that this problem existed in the United States with tremendous variability in adherence to guidelines, tremendous variability in outcomes, both short-term surrogate outcomes and long-term oncologic outcomes, creations of stomas, and to try to create a program in the U.S. The initial ostrich group deliberately included a variety of hospital types, university, large clinic, smaller clinic, multidisciplinary group, private practice, from East Coast to West Coast, and included Canada. And that ostrich group spent the next 5 years accomplishing its mission of showing that there was a problem and that something could be done about it. I was privileged to be able to go to the Commission on Cancer on behalf of the ostrich group and present the data to the accreditation committee, and thankfully both the accreditation committee of the Commission on Cancer and subsequently the regents and officers of the American College of Surgeons endorsed the program. And then subsequently between 2014 and 2017, standards became established. 6 pilot surveys were undertaken in the first quarter of 2016, and the standards manual has now been completed and is imminently going to launch. The standards manual is basically the guideline for what needs to be done to help ensure best outcomes for patients. It's been done with the collaboration of the American College of Radiology. It's been done with the collaboration of the College of American Pathology, and very importantly, also a variety of other surgical groups who came into the ostrich early on with people active in those groups, including the American Society of Colorectal Surgeons and others, Society for Surgery of the Alimentary Tract, Society for Surgical Oncology, Society of American Gastrointestinal and Endoscopic Surgeons. So the dream of having a national accreditation program, as is the case in Europe, is becoming a reality. Over 300 hospitals have expressed interest in the accreditation process. The standards manual explains what needs to be done. This program would not have been achieved without the tremendous support not only of the ostrich group, whose members I've mentioned, but also the American College of Surgeons, Dr. David Hoyt, the executive director, the Commission on Cancer with David Winchester as the medical director of the cancer programs for the American College of Surgeons, the immediate past chair and current chair of the commission, Dr. Dan McKellar, and Dr. Lawrence Schulman, and the chair of the accreditation committee, Dr. Danny Takanishi. All these people have been hugely important in making this project go forward. The College of American Pathology with Mary Kay Washington and Mariana Barrow, and many people from the American College of Radiology who've really helped make this dream of optimizing outcomes for our patients in the United States into a reality. So on behalf of the Ostrich Group, I'd like to thank all of the people who've helped make it into a reality.